Alright, so when doing injections on the knee, is there a reason why you would want to use an ultrasound as opposed to just kind of going palpation guided?
Yeah, so the reason is for increased accuracy. So when you're doing a blind approach or a palpation guided approach, it's about 70% accurate, if I'm remembering the research correctly, whereas with ultrasound or fluoroscopy, you're anywhere from 95, 96, upwards of 100%. And part of the reason for that is on the anterior aspect of the knee, when you're doing that, the medial or the lateral eye approach, you can be in the fat pad and not in the synovial membrane yet. And when you push, because fat is loose areolar tissue, it's going to feel like you're in the joint. And so you might go, oh yeah, I'm in the joint, when in reality you're in the fat pad. And so because of that, the accuracy isn't as high as it could be. And so my kind of standards that I've set for myself is that if I'm ever doing anything intra-articular, I'm using image guidance. And whether that's 5%, Prolo, whether that's PRP or stem cell, I'm using imaging. And then anything PRP level and higher, I'm using imaging as well. And there are certain instances, and this is a lot of what I do when we start getting into like treating ligaments and broad tendinentheses, is that I'm using the ultrasound to locate, okay, here is the region of where the MCL is attaching, and then I'm going to use the ultrasound to guide my peppering. Because what you have to be careful of, and you'll see this if you ever go out and you ever shadow other docs who weren't trained in palpation-based Prolo, they were just trained in doing intra-articular injections and things like that, is they'll find the one slice of the MCL and then they'll do like 2 injections and then they're done. And that doesn't cover the whole breadth of the actual attachment. So you have to be careful to not rely too much on the imaging and just say, oh, well, I saw the MCL in one slice and I treated 2 spots. And so it's not that I'm using the imaging just to get those few spots. I'm using it to kind of locate, okay, here's the area for them that MCL is attaching, and so now I'm going to go through and I'm going to use my ultrasound to guide my peppering of the area. And so with PRP and higher, the reason I do that is just because patients are paying significantly more money, and one, it's really good to be able to show them, okay, here's what we're going to be injecting and that kind of stuff. That helps them feel a little more comfortable and confident with your treatment. Frankly, it probably increases the placebo effect of the treatment, which, hey, if we can add in imaging and that improves their outcome just because of placebo effect, I'm cool with that. So that's kind of my standards that I set.